And then when we talk about sort of medication assessment, right? So taking a look at patients' medical history, I'm looking at all the medications they may be on and sort of putting those medications to different buckets, whether they are weight positive, weight neutral, or weight negative. And the goal is to get patients sort of to transition them off of some of those weight positive medications and get them to weight neutral or weight negative medications. And so we want to take away any other contributing factor that could be causing patients to have difficulty with weight. And so sometimes it's as simple as us talking to their therapist or their primary care doctor or their gynecologist or endocrinologist to say, hey, instead of this, pioglitazone that's often used for diabetes, what about using metformin or what about using Ozempic? Because these are things that we know are weight negative. Whereas we know pioglitazone can be weight positive and cause a little bit of weight gain. So we want to give patients every single bit of effort, every opportunity to be able to get into take away all those possible contributing factors. And then sort of we talk about medical history and things that can contribute, right? So if we think about medications first and then think about sort of those things that also can happen. So genetic syndromes, which are pretty rare, medical conditions, if somebody's recently had a surgery or has something going on with their joints or certain types of sleep disorders, cardiac liver disease, vitamin deficiencies or hormonal imbalances. And the big piece, the very big piece is getting patients psychological behaviors and conditions well controlled as well. So whether that be night eating, anxiety, depression, binge eating, these are things that are important to address as well. And now that brings us to sort of anti-obesity pharmacology. And so this is one of those things that I think is sort of taboo, sort of in medicine. I think a lot of it is stemming from a lot of weight bias and not understanding sort of obesity in general. And so let's get into that. And so these are medications that have been FDA approved and come out over maybe the last 10 years or so, but they're underused, right? And so this is sort of mind-boggling to me, it being used in sort of conjunction with the physician that is sort of helping you with lifestyle changes, of course. But as I talk to my patients and I tell other physicians when we do talks, if a patient comes to the emergency department with a blood pressure of 180 over 100, you would not send them out and tell them to go lose weight to help them with their blood pressure. You would treat their blood pressure. So why is there such a sort of a stigma around helping patients to gain weight loss, which we know is going to help those other sort of medical problems, right? We know that with a 5 to 7% total body weight loss, we can see reductions in blood pressure. We see reductions in hemoglobin A1C or that diabetes number. We see reductions in cholesterol as well. We see also reversal of fatty liver disease with as little as 5 to 7% of their total body weight loss. So why not give patients these extra tools in addition to helping them understand those things we talked about before with serving sizes, food labels, and those sort of things, but giving patients as many options and tools available. And what I've seen is that there's a lot of sort of bias from patients. Patients will say, well, I don't want to take the easy way out. I need to be able to do it by myself because something is inherently wrong with me, right? Or physicians even say, oh, they should just diet more and just move out a little bit more, right? And so getting people to understand that, again, from that very first slide is not quite that simple. Also, the another thing is there's a panic of sort of some of these old drugs from like the 90s, right? So there's all this investigation and fen-phen is this, this miracle that came but caused a lot of issues. And I think there's a lot of panic because of these sort of older medications that were removed from market. And so some of the ones that were withdrawn are listed here. And so usually those reasons were like valvular heart disease or pulmonary hypertension. One of them had some psychiatric side effects as well. So it was never sort of even brought to the US. But usually sort of things that sort of happen with the heart. But just like with any medication, we always have to make sure, that's why we say to be under a physician's sort of monitoring, because I'm always going to be monitoring people's blood pressure and side effects and symptoms and making sure that if somebody has uncontrolled blood pressure, then you won't be a candidate for some of these things in the first place. And so things that we sort of currently on the market are Xenical or Ali or Orlistat. And that one is a medication that is used to sort of reduce sort of fat absorption. So if some person has a higher fat diet, they take this medication and it reduces that absorption. And that's sort of how it works. Casimia is a dual medication of phentermine and topiramate. And this one acts by sort of revving up your basal metabolic rate and reducing sort of that portion intake that we're having. So often we'll use this one in patients that say, I never feel full. I am hungry all of the time and I just cannot get full, right? And so this helps to be able to help your brain correlate with sort of the new things we're teaching you about portion size. And it's really just overcoming that habit. Contrave is a dual medication of naltrexone and bupropion. This one is often used in patients that have emotional eating, that have binge eating, that have sort of snacking and grazing. It helps with that sort of that addiction to sort of food, right? Saxenda or liraglutide is a GLP-1 receptor agonist. This one works on that GLP, those hormones that come from your small bowel and go to the brain to help with appetite suppressant. This one's a weekly injection. But then the newer one on the market is sort of one most people don't want to inject every day. So semaglutide is a weekly injection and also a GLP-1 receptor agonist, and it also works very well. And so these medications are approved for long-term use. So I normally will tell patients that, remembering what did we talk about in that first slide? Obesity is a chronic and relapsing disease, right? And so we know that most patients will need this for a longer period of time. And it's sort of until we get patients to that habit. So where we've changed that microbiome, we've changed those behavioral habits, we've changed you into a way in which is now a way of life. It just no longer feels like something that you're working towards or hard at. There are short-term medications that are sort of approved, but we know that this is a chronic and relapsing disease. So I don't use them very often, but they are available. And so when we dig into like the data, what are we actually getting from these medications, right? And so this is a slide I just made from putting all of these studies together to be able to determine sort of how much weight loss you get on each medication. And so this is to look at the percentage of patients in these studies that got at least 5% total body weight loss. Now, remember, 5% is that cutoff we use because that means that we know we're making changes in diabetes number, high blood pressure, and cholesterol with just that 5%, right? And so blue is the control, meaning no medication at all. They are just testing what these patients were doing, sort of them, they were getting some type of placebo typically. And then orange is sort of the low dose of the medication, and Casimia has a higher dose. So that's the high dose of medication. And so what we see, the orlistat seems to get a lot of a good use here and a lot of patients that got at least 5%. I got to say, I don't see that typically in sort of practice because you have to be on a high fat diet for that to work really well. But Casimia, you'll see the high dose. So we got about 68% of patients that achieve 5% total body weight loss. Contrave over 50%, and then Saxenda over 50% as well. And then when we look at the percentage of people who got over 10% total body weight loss, so now we're talking double, right? We see orlistat about a little over 40%, the high dose of Casimia about 48%, Contrave about 28%, and Saxenda a little bit lower with about 5% of those patients that got over 10% of their total body weight loss. And then when we look at weight loss in kilograms. So what does this mean? So what does this percent body weight mean, right? So in kilograms for orlistat, we saw about 11 kilograms. That ends up being about roughly 22 pounds. For Casimia, we see about 14, let's say. That's about 28 pounds of weight loss. For Contrave, about 6 kilograms, so about 12 pounds. And then Saxenda, about the same. So as we can see, we have sort of pretty nice ranges of sort of weight loss that patients are able to achieve by just adding on one additional thing in addition to their diet and lifestyle changes. The other one I put on a separate slide because they sort of did the study a little bit differently with the semaglutide or the Wegovy. They did sort of a run-in period where they gave everybody the medication initially, and then at 20 weeks, they switched one of those groups to placebo to see what would happen, and then they kept one of them on the semaglutide. And what you see is they all lost weight during that first sort of 20 weeks and about 10% in their change in their total body weight. And when they switched people to that placebo, you saw they went up to that, they started to gain that weight back, right? There's people who continued with that weight loss. And so that was sort of how they did the trial. So a little bit different. And so they also broke it down by patients who lost greater than 5, 10, 15, and 20% total body weight loss. And they were comparing people, the placebo group, which is in the light green, and then the actual control, the group of who got the medication in that darker color. And as you can see, the people who continued on the medication achieved greater weight loss, right? So almost 85 to 90% of patients at least achieved 5%. So that's amazing. So we're reducing metabolic disease, right? You got almost 79, 80% that got over 10%. And then we got about 65-ish% with over 15%. And then you got about 40% with over 20% total body weight loss. This is huge for us in medicine to get people to be able to get that much total body weight loss with a medication, right? And so that is why I think these medications are helpful in the right setting, of course.